This is going to be controversial and it may upset some people, but I've kept quiet long enough as I've waited for more evidence, and patients deserve the facts. Welcome to this Sunday's Paper Roundup, where I read the paper so you don't have to, coming from sunny Naples, Florida. Let me start by stating that my views are my own and they don't represent my employer or any company that I work with. I'm a knee surgeon, yes, and before anyone says I'm defending surgery to protect my practice or my income, let me be clear. I am completely comfortable treating many ACL injuries non-operatively. I routinely recommend a period of structured prehab first, unless there's an urgent indication to operate a locked knee, major meniscus pathology, an important cartilage injury, gross instability, or very specific elite sporting demands. If you follow my content, you know that I could not be any more pro-rehabilitation. So this is not anti-rehab or anti-non-operative management. This is anti-hype and anti-weak science. This week's paper comes from the Clinical Journal of Sports Medicine, where a group from Canberra evaluates the cross-bracing protocol. And the headline is brutal. In active patients aged 16 to 40 involved in pivoting sports and intending to return to pivoting sport, the cross-bracing protocol had a 70% recurrent instability rate versus 2.5% in the surgical group. A 54% medial meniscus tear rate in the cross-bracing group versus 2.5% in the surgical group, and significantly worse patient-reported outcomes across the board. The authors concluded that cross-bracing had an unacceptably high failure rate relative to surgical stabilization. That is not a near miss. That is not a subtle signal. That is damning. Now let's step back and compare that to the original 2023 cross-bracing paper. Out of interest, I couldn't work out why it's called the cross-bracing protocol. I genuinely thought it was to do with the brace position until I realized that cross is named with the two senior authors. That paper was a case series, not a randomized trial. It enrolled 80 consecutive patients, all treated with the cross-bracing protocol with no control group. Patients had their knee locked at a right angle of 90 degrees for 4 weeks in a brace. The motion was progressively increased until brace removal at 12 weeks. Patients were informed the cross-bracing protocol was experimental. They selected it by preference, so some selection bias perhaps. And the paper itself concluded that longer-term follow-up and clinical trials were needed to inform practice. The main headline from that original paper was that 90% showed MRI continuity at 3 months. But continuity in MRI is not remotely the same as a normal, stable, durable ACL. An image of the ACL with the legs straight while the patient is lying flat on their back in the MRI scanner is not the same as testing stability when stressing the ACL. And even in their paper, only 50% were ACL OAS grade 1, while 40% were thinned or elongated continuous ligaments, and 11 patients re-injured their ACL by follow-up. That distinction matters because the whole social media push around cross-bracing has been built on one seductive idea. Look, it healed on MRI. Some clinicians and creators have become heavily invested in this approach. Cross-bracing is no longer just a treatment idea. For some, it's become a position. Once a treatment becomes part of someone's platform or income, objective debate becomes harder and critical appraisal can become uncomfortable. So I have no doubt this will generate strong reaction from certain people, but that is fine. Proper scientific scrutiny matters even more, and patients still deserve an honest reading of the evidence. MRI continuity is not the same as normal biomechanics. It's not the same as resisting anterior translation. It's not the same as controlling a pivot shift, and it's certainly not the same as proving safe return to high-level pivoting sport. This new 2026 paper matters because it finally asks a clinical question that should have always mattered most. What happens to real active pivoting athletes over time? And the answer was bad. Now, to be fair, this new paper also has some limitations. Let's discuss them. It wasn't randomized. Patients chose treatment. The authors openly state they originally intended in a randomized controlled trial, but patients refused random allocation. It's a single surgeon, single practice study, which limits external validity. And yes, critics will say this was not the same cohort as the original cross-bracing paper. That's true. This new paper actually excluded meniscal tears on MRI, other significant ligament injuries, and importantly excluded ACL, OAS, grade 3 tears on MRI because the authors felt those patients had too little biological potential to heal. In other words, they selected a more favorable population for healing, which frankly makes the poor results even harder to ignore. There's another issue that people need to stop pretending is trivial. The cross-bracing protocol has already started to mutate into a moving target. The original paper included protocol deviations, early brace removal in some patients, PRP in some patients, DVT prophylaxis added after only some patients had DVTs, and a later extension of the brace protocol from 9 to 12 weeks. And then we get a follow-up 2026 ACL Arch viewpoint, which is not a validation study at all. It is a viewpoint article proposing MRI criteria based on experience in managing 1,080 active individuals and athletes with the cross-bracing protocol, and explicitly says these observations are intended to inspire further research and that reliability and predictive performance still needs to be tested. It also discloses that the senior author has run paid courses on teaching the cross-bracing protocol to physios and has received brace donations from brace companies. So when people say you just need the right MRI features or this paper didn't follow the real protocol, my response is simple. You don't get to widely market a protocol on the basis of early MRI continuity, and then when outcome data goes badly, retreat into post-hoc subgrouping and shifting selection criteria. That is not mature evidence adoption. Now the practical question. Do I think non-ruptive ACL care has a role? Absolutely. Do I think every ACL needs surgery? Absolutely not. Do I think the cross-bracing protocol should currently be promoted to active pivoting athletes as a credible alternative to reconstruction? Categorically no, not in this evidence. The strengths of this newer paper are that it used a clearly defined high-risk sporting population, had 2-year follow-up, compared cross-bracing protocol against surgical stabilization, reported real clinical endpoints that matter: instability, meniscus injury, and patient-related outcome measures. Its weaknesses are a lack of randomization, single surgeon design, treatment selection bias, and imperfect MRI accuracy. The authors themselves acknowledge these limitations. My bottom line, the original paper showed promise for MRI continuity, but it did not prove durable functional stability. This new paper suggests that for active pivoting athletes, the protocol fails too often, too late, and with too much collateral damage. So what's my verdict? Should you ignore it? Should you be aware of it? Should you consider it? Or should you go ahead and change your practice? Well, my verdict, go ahead and change your practice away from routinely recommending cross-bracing for active patients return to pivoting sport. Not because I'm anti-non-operative care, because I'm anti-selling hope where the outcome data now looks this poor and patients risk ongoing instability and irreversible secondary meniscus or cartilage injury with the potential for lasting harm to the knee. Stay tuned for more. I'll see you next Sunday.